This is Selma Schimmel at the 14th World Conference on Lung Cancer, WCLC, which is organized by the International Association of the Study of Lung Cancer, the IASLC, in Amsterdam, the Netherlands. And now I'm joined by Dr. Jong Park, who comes to us from Seoul, South Korea. Dr. Park is the chairman of the Department of Thoracic Surgery. He is the director of the Lung Cancer Center at the Korea Cancer Center Hospital, there in Seoul, South Korea. And you're also the chair of the Early Detection and Prevention Committee for IASLC, the Regent for Korea. Welcome to the group room.
Thank you.
You coming from Korea really helps our viewers understand that physicians are invested in the study of lung cancer all over the world, and this kind of meeting lets doctors come together from all parts of the world to talk about advances in the diagnosis and the treatment. Now, you're a thoracic surgeon, which means that the patient doesn't see you first. How does the patient come to the thoracic surgeon? Because in lung cancer, there's a team of doctors, a multidisciplinary team. Talk to us about how the patient finally gets to the thoracic surgeon.
As you introduced me, I am thoracic surgeon. Usually, Department of Pulmonology or medical oncology refer the lung cancer patient to me when whose status is indicated for surgery after evaluation of the lung cancer status. In this process, several specialists, for example, a surgeon, pulmonologist, medical oncologist, radiologist, pathologist, join to evaluate the patient. Always a multidisciplinary approach is important for the good result of lung cancer diagnosis and treatment.
Dr. Park, in order to resect, in order to remove lung cancer, how small or how large can a cancer be for you to be able, hopefully, to successfully remove the tumor?
I think the size of the tumor is not important for removal. The most important thing is where the tumor is invasion to the very important organs. So, lung cancer is divided into 7 stages from early to terminal stages. And the patient who belong to the first, fourth, or fifth stages, the patient are able to take surgery, and the patient usually referred to me. The patient who referred to surgical part have cure potentials.
If a patient already has lung cancer that has spread to other parts of the body, will you still do surgery?
No, in that case, there is no advantage for taking surgery. So in that case, I usually refer to medical oncologist or therapeutic radiologist.
So what you're saying, it's a really good thing for lung cancer patients when they're able to have surgery to remove the disease.
Yeah.
In Asia, you have a large issue with cigarette smoking, which probably means that you have also very high incidence of smoking-related lung cancers. Talk to us a bit about the differences in how people talk about lung cancer, understand lung cancer, and also the approaches you as a surgeon in dealing with lung cancer. Is it different in Asia than in other parts of the world or the US?
The smoking population is definitely higher than US. But nowadays, the smoking population is decreasing tendency. So smoking causes the specific type of lung cancer, naming squamous cell carcinoma. In US, the most popular lung cancer is adenocarcinoma. Several years ago in Asia, the most popular lung cancer was squamous cell carcinoma, but nowadays, the most popular lung cancer in Asia is also adenocarcinoma. I think to cure, to diagnosis or to cure of lung cancer is very important, but prevention of lung cancer is very important. And one of the things is tobacco control is very important, I think. And for that, education of the public is very important.
Does the public in your country understand the association and the dangers of smoking and lung cancer?
Absolutely, yeah.
And is there a different perception, culture? What role does culture play with this disease?
It's very difficult to say about the culture difference of lung cancer. Most definitely proven evidence is just smoking. So lung cancer incidence is very parallel with the smoking populations until now.
Because you're involved heavily with IASLC in the early detection and prevention with the committee that you sit on, what do patients need to know now about lung cancer screening?
National lung cancer screening trial result was reported last November. But however, NLST result cannot explain everything. For now, individuals who have the smoking history and aged over 55 recommended to have discussed with their physicians whether to undergo CT screening.
Dr. Park, how does membership in IASLC benefit thoracic surgeons, especially in Asia?
I guess there are lots of benefit through IASLC membership. In terms of new diagnosis, new therapeutic method, and new research, prompt information exchange and joint research is necessary, I think. I think it is possible by using teleconference or another email discussion through IASLC memberships. Also, it's possible to have some help about patient referral, patient consultation, and joint workshops. I think there are lots of benefits through IASLC membership.
Dr. Park, thank you very much for helping us understand the role of the thoracic surgeon, the multidisciplinary team, of how all these doctors come together in partnership to help that patient diagnosed with lung cancer. Dr. Hong Ho Park, Chairman of the Department of Thoracic Surgery, the Director of the Lung Cancer Center at the Korea Cancer Center Hospital in Seoul, South Korea. You are also the Chair of the Early Detection and Prevention Committee of IASLC, the Regent for Korea. Thank you so much.
Thank you.